presentation of your study. Professor Zoltán, the question is for you. You looked at glucose and ketogenic diets in mental health. I wonder whether looking at also the fats that's consumed might be important.
So that's a really good question, and that gets us to one of the major challenges in the field of ketogenic therapy and its potential mechanism of action. At the moment, I don't know that we really know whether it's the low carb, extremely low carb, so having less than 20 gram carbohydrate consumed a day. Is it the ketone body that circulates in our body? It could well be. We know that beta-hydroxybutyrate has a number of highly beneficial effects. It's not only a source for ATP, actually a much richer source of ATP than glucose, but it also has anti-inflammatory effects. It has epigenetic modifier effects, HDAC inhibitor. And we don't know whether it's the interaction between the diet and the gut microbiome. And it's all those good metabolite short-chain fatty acids that tend to be produced in the form of butyrate and propionate when we eat ketogenic diet, or the combination of all that. So that we don't know. And coming back to your question specifically, the type of fat. So that is really interesting. We published a book chapter a couple of years ago. My PhD student came up with this idea that while she was reading the literature, she realized that it's so lousily reported. They never really point out the omega-3, the omega-6 type of fatty acids. And when she put the tables together, it became obvious that, yeah, it's highly variable. So how much is it really, the different kind of fatty acids that contribute in it? Because in parallel to all of our ketogenic diet interests, there is another stream within sort of nutritional psychiatry, the omega-3 fatty acid story, which seems to be working in one hand, but on the other hand, maybe not so much. It depends on what kind of omega-3 fatty acids we are talking about. So, yeah, I think that's all possible, and these are all open questions at the moment.
It's your turn.
My turn, okay. Thank you.
Yeah.
May I? I have no doubt of the validity of your results.
Please.
My own experience of 7 years of caring for my late husband, who was cortically blind, frontal lobes and memory all affected by a series of strokes. I changed his muesli breakfast for bacon and eggs, removed pasta bread and sugars with marked improvement. I similarly have a number of normal friends who went on ketogenic diet and boasted massive improvement in their mental state, their anxiety levels, their physical strength, and even got better on carnivore. And these are normal people. Namtodom. I know several studies, one out of Scotland, where long-term people, women with schizophrenia, had gluten removed from their diets, and 20% were apparently entirely cured. And the others all felt a lot better. So I was wondering if you're planning to control for gluten-containing substances in your next study.
In our ketogenic diet arm, their glucose intake will be controlled in a way that it should be less than 20 grams a day. And that will be very carefully titrated by our dietitian, closely overseeing what they eat. And our patients will also be asked to measure their blood ketone levels every day and report that. Because if they are not in ketosis, if their blood ketone levels are not increased, they are not on ketogenic diet. And if their glucose intake is higher than 20-ish per day, they are not going to go into ketosis. Gluten. Oh, gluten. So I missed that one. Sorry about that. So that's a really interesting comment, the gluten one, because the very first modern study, which we refer back to in the ketogenic diet literature field, published by Dr. Westman in the late 1980s, they actually provided a diet for an individual with schizophrenia as a gluten-free diet. It was not actually given as a ketogenic diet. It just happened to be a ketogenic diet by the fact that it was gluten-free. And that person immediately improved. She lost a very significant amount of weight. She was in her early 60s at the time, having the history of schizophrenia for 40 years. So 2 years ago, the same group published another case study series, and one patient in that series was the same lady in her 80s now, still maintaining a life independently, not having psychotic episodes at all, and maintaining a normal body weight, still on ketogenic diet. But it all started as a gluten-free diet. So that's really interesting.
So Zoltán, this is a question for you. I'm a GP. I would love to be able to prescribe ketogenic diets to patients with quite significant, severe psychiatric illness. Do you have any tips for how we can, I guess the backstory to this is that I really struggle to contact psychiatrists, both private and the public sector. Do you have any tips, and I'm sure that's a sentiment shared by many of the GPs here, do you have any tips for how, I guess, we can introduce this one into our clinical practice, in terms of the pragmatics of it, and two, any tips for, I guess, collaborating with psychiatrists in this regard?
So I think an interaction between psychiatrists and GPs are absolutely critical to not only for the management of the actual patient, but moving the field towards. That's how we are going to start recruiting. We are talking to the GPs in our area and try to have access to their patients. And what's critically important, again, to have their buy-in to this whole idea of ketogenic therapy, which will be challenging in some cases because of all the prejudices we have mentioned earlier here. But I think this is absolutely critical. Especially if we imagine this to be a regular part of their treatment schedule. And I think lifestyle interventions, not just ketogenic therapy, but helping them to get moving, physical activity, aerobic exercise, and these sort of things will become very important as well.
This is to both of you, I think. How concerned are you about current reviews? For example, the polycystic ovary syndrome guidelines have come out and they've said not enough evidence to really look at low carb. And now the dietary guidelines, the standard Australian dietary guidelines are under review. And there's this word starting to appear that they might apply to anybody at risk of chronic disease, which means they're broadening this. Well, I'm wondering, am I being too suspicious in thinking that they're wanting to broaden their scope a little bit more so they can keep saying more of the same and still say the data doesn't exist for ketogenesis or low carb? How worried are you?
Well, I think a lot of clinical practice guidelines for different conditions often like to make the claim that there is insufficient evidence. It was interesting with the type 1 clinical guidelines, which are still the same now, they haven't been updated. They said there's insufficient evidence, but no one had actually gone out and looked. There was not a single systematic review comparing low-carb diets and high-carb diets. We were the first ones to do it. And the data was indeed limited, but I don't think it was fair for them to say that there is no evidence. And so I think oftentimes that claim is made incorrectly. And then when you look at the studies that back up or support the Australian dietary guidelines, they generally exclude people with risk factors and they exclude people with chronic diseases. So unless they're going to use studies that actually have, people that have risk factors or have people with chronic disease, then that, in my opinion, isn't evidence-based practice. So I'm not concerned about it.
So in terms of clinical guidelines, and as they may or may not relate to ketogenic therapy, in Australia, probably first time anywhere, in the guidelines of managing depression, diet has been promoted. So it's lifestyle changes, diet, physical activity. They were not thinking about ketogenic diet, of course, but that's all fine. It's the Trojan horse which gets us into that mindset that there are nutritional interventions that produce measurable biological, metabolic effects in the brain. I think that's the most important part of that message.
So nutritional psychiatry is a burgeoning area, and whether it's ketogenic or Mediterranean, there's some commonality, and that's less ultra-processed food, no sugar. Now, I work in a hospital, and this applies to any chronic condition. You walk into a hospital, and that's not what we see delivered. And so I guess it's really frustrating, isn't it, that when we want to treat the sickest patients, we can't actually start that treatment at the fundamental level and addressing the foundations of that metabolic pyramid we saw this morning until we get out of hospital. So I'd just like both of your thoughts on all the research that you're doing, how do we translate that into a hospital population in which we've got the sickest people? Easy.
Good question. I had to work in a hospital for 6 months as part of my my placement when I was training to become a dietitian. And you're right, the standard meals for people in hospital aren't that great. But in a lot of hospitals now, patients can actually request to make changes. And so one of the jobs we were doing was going around to the patients and asking them if they were happy with their diet and they were happy with the food that they were getting and if they were actually eating it or not, and if they did want to request any changes. That service probably isn't always provided. We were students, so we had to be there doing it. I don't know if that would be done if we weren't there, but there were a lot of patients that requested to make changes. They do have a diet label called a ketogenic diet. It may not be the most perfect ketogenic diet, but it's still probably a lot better for people who want to follow a low-carb diet in hospital. So my recommendation would be to, if you are in hospital or your patients are in hospital, request to speak with the dietitian, because the dietitian can potentially help you make changes to your meal plan in hospital.
I always tell my patients, if they're in hospital, they need to bring their own food with them, or get their relatives to bring in a couple of eggs. And especially after colonoscopy.
I'm not working in a hospital environment, so I'm probably lucky in that sense. But I do share your sentiment about not making available potentially therapeutically beneficial dietary approaches. And it's a difficult environment, highly administratively and bureaucratically regulated, so I can imagine the last place to change. But what's important is to the evidence to come out. So I'm currently working with two different groups, one in Hungary, one in actually in the Philippines. That colleague is a PhD student of mine. So he's setting up a ketogenic diet trial in a hospital environment where the hospital delivers the ketogenic diet for the participants during their stay. And the other one in Hungary, my colleague is the head psychiatry in one of the regional hospital psychiatry unit, and he already has a number of patients, inpatients, on ketogenic diet. And if I think as the reports come out, that should be the way to convince the bureaucracy that this is something that has to be taken into account. Because patients will benefit, therefore hospital stay can be shortened and they can save money in the end.
First question for Jessica, the sustainability of the ketogenic for type 1 diabetes and the improvements in hemoglobin A1C. And I think you mentioned that you saw a reduction down to 7.1. Do you see, you gave a little hint of follow-up, do you see the hemoglobin A1Cs dropping to, quite significantly down to less than 6? And related to that is there a subset of carnivore, like more restrictive diet, and any observations about effect on A1C?
So we were running the trial, participants were coming in at different time points. So one of the more difficult things with us is, the first people that were coming through the trial, they were doing their low-carb diet in the middle of lockdown. So there was no takeout food, there was no restaurant, there was no socializing. They did really well. So it was kind of easy for the first few. They adhered to the diet really, really well. They thought it was great. They didn't really experience any challenges about, going out to parties and things like that. The next group of people were very difficult because they started the diet during lockdown, and then halfway through the intervention period, all the lockdowns were lifting and all the social events were happening again, and people, wanted to celebrate the fact that they were coming out of lockdown. So it was a little bit more difficult to adhere to the diet, and those people struggled a little bit more. And then the last group of people that came through, perhaps it was even more difficult for them to even get started on the low-carb diet because they were starting when lockdowns had lifted. So we had a range of adherence. But, as I said with type 1 diabetes, they've been told their whole life that carbohydrates at every single meal are so, so important. For some of the participants, it took 6 weeks to get their head around the fact that they could eat a low-carb diet. So I think that we were actually starting to get some really, really good results, but then the study finished. So we do have that follow-up period where we didn't intervene at all. So after the intervention period, we just kind of, sat back, let participants do what they want. And we followed up again in another 12 weeks. And a lot of participants continued to improve. So more than 50% decided to keep going with the low-carb diet, and their HbA1c levels did come down further. So hopefully we will publish those results as well. Did you have another part to your question?
Can I just
Jane's
make
going
a
to give
comment
some
actually
real...
about your first question? I was just wanting to make a personal comment. Really, to answer your question, I've been doing low carb. I'm a type 1 diabetic, low carb for 5 years now. My A1C has been around 5.3 for 5 years. Using half the amount of insulin that I was on before, let alone all the other health benefits of, improved mental clarity and et cetera, et cetera, et cetera. So personally, my experience is, yes, it's long term, it's very sustainable, and it gets easier and easier.
What did you start at, your HbA1c?
It was 8 when I started, and it's been about 5.3 for 5 years.
On the same topic, I'm type 1.5 and my A1C is 5.5, but I'm aiming for less than 5. Yeah. So we're running out of time? Yeah. So how long, Jessica, are you expecting to follow up your cohort?
I am no longer at the university, so I won't be continuing to do that. We might, in the future, when I find some time, be able to get some more ethics to follow up with the group again down the track. I'm still in touch with a lot of the participants. They can reach out to me anytime, of course. They have my details. And I have had some really good feedback from them about, how they're continuing to improve further. I think you mentioned before as well, going really low carb and carnivore and what that can look like. We had one participant in the study who, once they kind of got their head around low carb and they realized how easy it was for them at least, they found it easier to just cut all the carbs out than bring any in at all. So they sort of almost did a very low carb carnivore diet because they found that easier. Their HbA1c started at 8.4 and it finished at 5.6. That was after the 12 weeks. And at the follow-up time point, I believe it was 5.1. And their endocrinologist thought they had reversed their type 1 diabetes.
So I have a question, Jessica. So I actually partially brought on by Ron Raab, who I sent a copy of your study, or the study that you did with Ron, and I just showed him that he was being quoted, and he talked about how he participated in that and about hypos, and that was my question. The people in the study, do they have less hypos? Because that's been my experience. You know, you talked about less glycemic variability, but being on less insulin, less hypos?
Well, our study, the actual outcome we were looking at was severe hypoglycemia, and our group didn't have a lot of severe hypoglycemia to start with, so it didn't actually change throughout the study. There was no change in severe hypo. But in terms of time in range, we had a significant improvement in time in range, and that included like lower blood sugars that weren't classified as a severe hypo, but they were still technically too low. So we were looking at time in range 3.5 to 10, and so participants were starting at about 55% time in range, and by the end of the study, the average was 76% time in range. So those low blood sugars did improve because they were using less insulin.
10 is still too high, isn't it?
We were just using the standard
I know.
range.
Just on the hypo issue, my hypos have virtually disappeared.
Amazing.
Yeah. As like the reduction in day-to-day stress, same for you? Yeah. It's just huge. It really is huge. It's a complete game changer. And obviously a CGM as well. Question for Zoltán. I may have missed in your content, but are you looking at any correlation between hemoglobin A1c and improvements in major mental illness?
That certainly will be one of our measures. Yeah. So we are really interested in not only the maintenance of ketosis in the patients on the ketogenic diet arm, but also their glucose metabolism. And that's an important factor, especially because we have a sort of a semi-active control group. We expect them to improve. The diet is certainly going to be improved to their usual diet. So if they start out with a somewhat worse glucose metabolism, we expect them to improve on that as well. It's really important to understand the link between the symptomatic improvement and the metabolic improvement. So it's a key factor for us as well.